introduction here. I appreciate Ashley's introduction. I'm going to share my screen. There'll be some time at the end of our of the presentation. Um, about 15 minutes to ask questions. So I know Ashley's kind of making sure to check in on the Q&A section of the webinar. So if you have any questions there, happy to answer them. And if we run out of time, I'm happy to answer questions thereafter via email. So in case you're just double checking you're at the right webinar, we're talking about integrated substance use disorder treatment with HIV care, thinking about how we involve inclusive strategies using SBIRT. So again, yeah, my name is Dr. Julia Lopez. I use pronouns of she, ella. I work at the University School of Medicine at WashU in infectious diseases. So a lot of my work is at the intersection of the mental health care, doing integrated behavioral health work in our clinic and in previous work that I've done in community mental health and physical health as well. So hopefully, I've been doing this work for close to 20 years. So ideally, I will have maybe a little bit of information for you all that if you can at least take a nugget of information that you find helpful today, that's my hope. I have no disclosures for you all today. And just to remind folks, kind of centering ourselves as to what it is that we're talking about today, these are the kind of three main goals of today. First, explaining the relationship between SUDS and HIV and how that looks like in relation to susceptibility, patient outcomes, and treatment. And then looking at the components of the SBIRT model, screening, brief intervention, referral to treatment, and how we can make that applicable in HIV care settings in particular. And then really looking at any of, the common challenges and opportunities in integrating SBIRT into HIV care and ways to think about practical solutions to that. So hopefully, again, that you all feel like there's some things that you can get out of today's webinar in relation to that. So just to make sure that we're all kind of sitting in the same page, I did see that, there's a whole host of different people, different backgrounds. I'm sure many years cumulatively of all of us together, hundreds of years of insights, experiences, and understandings. So I think that's really awesome. Making sure that we all are on the same page, I did want to start with some epidemiological context. So, in kind of thinking about SUDS and HIV, how they correlate, what do we know about current deaths and HIV related deaths? How do we see co-occurring health come into play? I just wanted to provide some of this context here. So what we have going on here is, and some of the more recent data that we have, although they're just updating them now. So hopefully we'll have some for closer to 2024. But overdose deaths have incrementally been going up over the course of these years. And comparably to HIV-related deaths, obviously very different. However, when we think about kind of the susceptibility, which is a different slide, we'll kind of talk about how those things interact. When we think about just overarchingly, not even as it relates to people living with HIV in particular, but just folks who are suffering from co-occurring mental health and substance use disorder, this is also trending, particularly in our youth. So if you look at any data that is in regards to SAMHSA in particular, that looks at that puts out their reports every year, you'll see that the kind of the trending number for folks with co-occurring disorders in particular is in our youth. So we're talking around like 13 to 25, 18 to 25, that age range. And then we also see that kind of also in a similar set when we think about who may be susceptible or have been infected with HIV, is also our youth, which is why we see a lot of our outreach and community work in relation to youth and adolescents. So you probably have heard this word it got real popular, I feel like in the last probably year and a half, the word syndemic, right? So really syndemic is just another way to say there are multiple things happening across various levels of a person's existence. May it be macro, may it be micro, may it be in community or in their patient care. And those interacting health crises are synergistic and really then leading to an even more intense kind of issue in relation to mental health, substance use, HIV care, etc. And so that's really what syndemic is really saying, kind of taking into account that we can't look at people in one facet and be able to kind of provide appropriate care, that there's going to be multiple angles to any person's care, and that we should be thinking about how are other people's disparities or the impact that they're having in their day to day is multiplicative in the capacity to be able to receive care. So I think we know that information from a just like even our day-to-day practice and work that we do. But then came kind of the language with that that's grown over the last couple of years. So when we think about substance use and HIV susceptibility in particular, um, and I specifically, just to highlight, I specifically use the word susceptibility, not risk. HIV risk is a lot of language that we see, but really is not trauma-informed care language. So, because if we think about risk, it's like, well, you're a risk, therefore you yourself are, you, the individual, are a risk, and having sex is making you a risky individual. All of that is very stigmatizing and not helpful. So I purposely and with much effort, try to write any kinds of presentations or work that we are doing to really work towards destigmatizing language. So that is why you'll see HIV susceptibility in this slide deck. So as we well know, the interaction between substance use and HIV is rooted in a whole lot of different things, but most often we think about the behavioral and biological mechanisms, right? So if we look at the kind of the behavioral aspect of that, what we do see is that when there are HIV outbreaks that we've seen across the nation, we are also seeing kind of like understanding root cause of those outbreaks are really important, so that then we can appropriately provide services and supports, and ideally, really, prevention level care for communities to be able to limit or mitigate or ultimately, ideally, kind of eradicate, right, those outbreaks in the first place. So what we're seeing here is of HIV outbreaks that have happened. There's been a lot of it is in relation to a whole lot of different systemic issues, but some of the ones that have been noted are in relation to people who inject drugs and perhaps that there's a limit or not really available um, syringe transitions and clean needle and harm reduction purposes and processes in place for those community places. And so another big kind of like when we think about uh, impact priority populations that are impacted by HIV susceptibility, we know that plenty of research, plenty of statistics that demonstrate sexual and gender minority individuals, so folks who are in the queer and trans community who have sex um, may have are a higher susceptibility for HIV transmission. This is particularly true around men who have sex with men. Um, and these things and at the intersection of methamphetamine use. So interestingly enough, I've seen in the clinic more and more people that I'm seeing in my own kind of patient care load is been folks who are using meth and kind of ways in which like to work through harm reduction, SBIRT, motivational interviewing, right? Some of these things that can be helpful to kind of support people in their substance use while also trying to maintain just healthy, maintain their HIV care in a way that helps with not transitioning into advanced HIV. What we do know, plenty of literature around this, around active substance use can lower and has been linked to lowering art intake, of course, here, increased viral load, potential risk of resistance. And this has a lot to do with like the blood-brain barrier, this idea that early entry of HIV into the brain and the triggering of release of neurotoxins, which can precipitate the brain swelling, right? So these are just some of the things researchers have kind of looked into to understanding the linkages between active substance use and how that may impact, HIV viral load and HIV risk of the resistance of the medication. So all that to say is that, more than anything, it's just to demonstrate I think what we all know already, which is the relationship that is very much relatable and multiplicative in nature when it comes to substance use, HIV, and being able to support people in a space where we know that substance use is very much um, is an is an addiction, a disease, and is not something that can just be kind of, okay, I'm gonna stop doing this and that's the end of that, right? And so a lot of times it's a lot of the workings of how do we support people where they're at, how they can actually kind of manage in the first place, and really thinking about ways in which we can kind of think of consider next steps for support. And uh, I'm a big proponent of uh, integrated care or interdisciplinary teams. I think maybe because I'm biased, perhaps because I'm so used to having been in that space. Some of that is, may because the clinic that a person may be working in is made up in that way. Sometimes we're kind of more siloed, and so sometimes not as available. And so we're having to do more outreach or resourcing outside of our clinic or outside of our place of work. And so I think that has a big thing has big actions because being able, for example, a patient being able to receive care from their case manager, their therapist, and their HIV care provider, and being able to have that team of support, there's a higher likelihood of being able to not fall through the cracks when it comes to their care. So I'm just gonna take a quick second here. Claire, your question around sexual and gender minorities, do you mean people under 18 or people of color? Yeah, great question. I mean sexual and gender minority, I mean LGBTQIA plus individuals. So sexual and gender minority individuals is just another way um to describe that. Sometimes we see that acronym as SGM. So no, it's not particularly relevant to like age or person of color. If we were to say that, then we would say, sexual gender minority who identifies as, fill in the blank, or an adolescent who is a sexual gender minority. So really, it's just another language for LGBTQIA plus individuals. Hope that helps. Um, okay, so here, pivoting to the SBIRT model. So this is, I think, really interesting because we hear and talk about this a lot. Like I think a lot of times post are like any type of um, training that we might have gotten, schooling that we might have gotten. There's sometimes I feel like I've definitely been in a lot of different settings where it hasn't even been like that's not something that was even in a part of the processes of receiving information for, right? And so we learn sometimes a lot of these kinds of modalities post our, quote unquote, training. And then when we're seeking out additional trainings, like as you all are doing, then these are the different modalities that come into play. I will say that SBIRT seems to be growing in nature, especially because we're growing in relation to integrated care settings. So previous and integrated care settings, when I say integrated care, I mean physical care with mental health care. Those really, I would say in the last like 15 years have been really developing across the nation. But if you were to look previous to that, it was pretty limited. We were pretty much like, here's your mental health care, here's your substance use care, here's your, your physical health care. So if you're receiving HIV care, you're getting that here. If you need a mental health therapist, I have to refer you out to someone else over here. And if you're needing substance use care, then I have to refer you to this other program over here. And so all that to say is that it's not so much that we have the referral process isn't necessary, because it most definitely is, but what we find is that integrated care, as it relates to a person's just holistic self, is if we can have it as much as possible under one roof, or if we have super strong referral to treatment processes, then we see that there again, this idea of like trying to help minimize the amount of barriers that an individual is experiencing in their day to day. If they're already battling an addiction, do we really want to be telling people that they have to go to 3 or 4 different places to receive the care that they need? Likely not, right? Because that usually is not gonna that just makes it a lot harder for folks. So SBIRT really came into play quite heavily when integrated care started to come into play more heavily. There's some really great integrated care setting work that's happening in Washington, Oregon, uh, um, in particular, which is really helpful. So if you're ever interested in just learning about integrated care as a whole, I'm happy to provide some resources and information about that, because I find that really important and interesting. Um, and so Esper, really thrives in integrated care settings, but also it can just kind of be a helpful, quick tool, quick model really to use, no matter if maybe you're not in an integrated care setting. Maybe you're just you're in your classic HIV care setting, or in a behavioral health setting or public health setting of whatever nature. What's helpful and why people find this particular model to be so effective is because a lot of times when we think about clinic settings, like your classic clinic setting, you don't usually have like a whole lot of time with people, right? There is a stacked day. Most of the time clinic slots are like 15 minutes long. If that, making sure that you're able to manage their HIV care, but then anything that may be coming up behavioral health wise and the substance use wise, and then really just like basic needs too that might be coming up. So a lot of can happen just in that 15 minutes. And so the reason why this model is really helpful is because you can do more of this rapid assessment to know if substance use is needs to be prioritized as part of their recovery, or as part of the care that you're provisioning. So the S is for screening. And what's nice, I think what's really helpful here is that there's a couple of screeners that you can use that can be like 1 to 3 question screeners. And if those don't demonstrate a screen that's positive for like alcohol use or some other substances, any kind of substance involvement, then you can kind of keep going, right? You can kind of move back to the care that you're provisioning previous to the substance use screener. But let's say that there is positive for one of the short screeners, then you would move into the more standardized assessment tool of that screener, usually the longer version of that, or you may have another system in place. If you don't have a system in place as of yet, this is a great opportunity to really kind of advance that in your clinic space if that seems like an option, right? So we have something we do SBIRT screenings. We use the SBIRT model as a mental wellness team regularly. And so that is something that we try to also employ with our healthcare providers in the clinic, so that then they know, okay, well, this person needs additional support. Let me refer them to a case manager or a therapist, so that we then can do the deeper dive with them, right? But what I what I really love about the screening part of this process is that anybody can like pick this up and do that. Even in a lot of times, sometimes the medical assistant will be the person who does these screenings. Or you may have a dedicated screener in your clinic, and then that would be the person who would do this. So can look a lot of different ways, but most important is having this first step down. If there's opportunity to incorporate this into the clinic workflow of the day, it can be really helpful. And so I'm gonna pause right here real quick because I wanted to show kind of like what screeners are we talking about. Likely you all have some ideas around this, but um I want to show this website, which is linked in the slide deck and which you all will receive later at the end of the of this webinar. But SBIRT Oregon, which I was saying, Oregon is solid with their integrated care and SBIRT kind of work. They have really a couple of cool things. One, they have this really interesting workflow for different patient categories, how you can respond to that, which is really nice. But here, there's different screening forms. And so there's different download options. And if those screeners have been have had reliable and validity testing done, they will also be in other languages, which is also fantastic. So a lot of times we'll use the audit C, which is the consumption. It's the shorter version. There's only 3 questions. But if the person is positive for that, then you would use the full audit, which is a 10 question, right? And then there is assist. There's a bunch of other ones that are maybe more relevant for those who are adolescents. So if your clinic sees a lot of adolescents, these are the ones that maybe you would use first, right? The clinic that I work in is 18 and over, but we do have an adolescent clinic. And then assist. Assist is for alcohol, smoking, substance use, substance involvement, and screening test. That's what that stands for. And so here, this is helpful because it doesn't just look at illicit drug use, but also prescription misuse, can be really helpful because more and more of what we're seeing has a lot to do with prescription misuse. So that, for example, is what I would say it would be helpful when it comes to, let me bring back my PowerPoint screen. Um, when it comes to thinking about screeners, right? And then using a more standardized assessment as you see fit. The B and the I is for brief intervention. So it's very time limited. We're talking here, if you find that the substance use is pretty extensive, then it may be stretching to a later to closer to the 30-minute mark, right? But here, this is where if you haven't already done or have more practice around motivational interviewing skills, this is where brief intervention, motivational interviewing skills come hand in hand very nicely. So here is where you're trying to kind of understand what do people understand their substance use to look like? Is it no big deal? Is it something that they've been thinking about? Do they have some ambivalence around stopping? This goes back to the theory of change, which is like, how much are they likely to feel like they're in a place to change now or change later? And so contemplation stage, pre-contemplation stage, like these kinds of things, right? Versus like, okay, I'm in the action stage and like actively not using, right? And having been in recovery for X period of time. So being able to have the wherewithal to know where are people's insights awareness around substance use is really helpful. And this is going to be super critical to be, as non-judgmental as possible. It's all about the ways in which you ask the questions, how you approach the questions. And that's where I say the motivational interviewing can be really helpful because that is the system for which we often work out of. So if you haven't done motivational interviewing kind of training or webinar stuff, I would highly suggest it and take a closer look at it. Referral to treatment is your R&T of the SBIRT, right? So here is, if the brief intervention, right, is one that is like, hey, I want to just kind of know where you're at. But let's say that the person is has pretty significant substance use going on. And it's going to be outside of the scope of what the clinic is offering or where you're working, right? So this is where it becomes critical, of course, to have your other specialized care services in your community or connecting them with that when you're talking about folks who may be on the more moderate to severe substance use disorders. And so um, now I would say that like whenever possible, if peer navigators have, are so important in every setting that I can ever think of. And so our community health workers, right? Like folks who may be able to assist with the navigation aspect around this, because it's one thing to say like I'm gonna send a referral or you have a spot, in a IOP, like an intensive outpatient program, right? But it's all about like, what can I even get there, right? Or is it going to be covered from my insurance? Is it not? If I'm underinsured, uninsured, these kinds of things. And so those are all kind of perspectives to take into account when you're thinking about how do we make sure that the referral to treatment is substantiated, right? And not just kind of a floating referral that doesn't really lead to anything further. So when we think about SBIRT and HIV care settings in particular, I mentioned the audit, see, and the assist. I would say that those are the ones that we use. I find them really helpful. And then there's the link that I showed that also has all of that additional information. So hopefully you find that beneficial. The brief intervention by HIV care providers. So this is anybody who's who's like working in the clinic, right? So you have your nurse practitioners, your MDs, your your social workers, your case managers, any trained peer navigator, using those motivational interview techniques is going to be super, super critical. Well, when the person is already in the clinic, it's kind of like, okay, this is prime time to really try to see if we can connect them, be able to support them, and being able to think about like what are safe, kind of safe ways of we're going to continue to use, what are those kind of safe ways to do that for their care, and also thinking about those alternative outlooks if the person is not ready or is kind of in that pre-contemplation stage of things for substance use. If you are a clinic that has co-located services, addiction services, that's fantastic. That's always super helpful. The integrated care setting is all about kind of is a spectrum, right? The spectrum is if we're fully integrated, we can think of it as like kind of like a one-stop shop where all of those things are housed in one space. But a lot of times that is not quite where we're at. And so we tend to be kind of on a different part of the scale of integration, which is co-location. And co-location is still really important and, still an area that I think can continue to grow. And we tend to be, I've noticed that there's been a co-location growth in relation to behavioral health and HIV care. And there has been some movement in addiction services, but I would say behavioral health has kind of progressed further. And so there is still a lot of advocacy and policy work that we should be doing to kind of support the addiction services co-location. And this involves specifically even the medication assisted treatment within HIV clinics. Because again, if we can really make things very simple for our patients because they already got a lot going on in their lives, then, that will definitely be support. Um, the other big part is if you don't have that referral process on site, then that kind of do we have an already streamlined treatment process? And so this can include the real-time scheduling that's shared with the local program that you live in, or is there lessened paperwork, more access, not as many like hoops to jump to get a person from, okay, they were coming here and now they're also going here, and really keeping the kind of the amount of like the paperwork pieces at a minimum, knowing that we do have to submit and provide that documentation because that's just the process that we live in and is important, but not to the point of hindrance for our patients. So here are some barriers to the SBIRT implementation because as with anything, there's always going to be some challenges. And so here is resource constraints. Literally, it's like I'm so down for all of this and it's important. I see the value and also like where's the money going to come from? And like that's a reality. And or we're already short on staff. We're already short on clinic people, trying to change the clinic workflow doesn't seem like an option right now, right? These things are very true, like very real, and I'm not saying that I completely understand them and have lived through them, and so I see like where there can be difficulties here. Same for like reimbursement incentives. Sometimes what we see an issue with, especially because with integrated care, is that if can certain things be billed in the same day or not, or is it considered double billing? There's all of these like policy perspectives around billing that can cause problems, and sometimes that's just really dependent on the state laws and things like that. So that's and that I think is another reason to be doing advocacy work around kind of thinking about how do we do integrated care and addiction services in HIV care settings and why that's important. Um, and just in general in integrated care settings. Then we have stigma, of course, right? So even if like you're coming in very trauma informed and without judgment and really trying to come into the space with a patient, there's still going to be some hesitation, especially if maybe the person hasn't really disclosed any of their substance use in the past. And really the already kind of medical trauma that a person may have experienced in the past because of the various identities that they might hold or because of their HIV status, these kinds of things. And so I think that that's a very real barrier for sure. And then there's the fragmented care delivery, which I think we all probably have experienced even in our personal lives, likely, right? So this idea of like, how do you manage HIV addiction services when there might be kind of the care delivery may not be fully set up, the coordination, or there's a delay, or if there's not integrated health records. And so I think a lot of times the integrated health records, I think, is slowly and surely getting better with, I think of a lot of times like with my chart at Epic and like supporting those things. But still, like the systemic change, the workflow, the education, policy environments, all of those things lead to a lot of those barriers that we do see in our day to day. And so I do want to acknowledge that these are realities. But that doesn't mean that we just kind of not do the things, right? So I think importantly here is overcoming. Like how do we kind of overcome those implementation barriers? What do we do to really make things look and feel different, right? Both for our patients, but also for us as healthcare providers. So training and incentivization, I think, is really important. So you all coming to this training, for example, and saying like, okay, I got a couple nuggets from there here. Like, how can I propose this in the space that I work in? Value-based incentives, I think, is important because people are maybe going above and beyond the work that they're doing, and like how are they being supported in that in various ways, and that can look specific to each location, but being able to recognize that people are focused and attentive to this work and being able to provide them um, resources for that, right? Workflow and system redesign. So is it more about the way that we even screen? Is the screening still only happening? Is actually like the workflow of using like an iPad or some type of tablet helpful? Does that make it harder? Do we have issues with like internet connection? What maybe would help with keeping things seamless and coordinating that? Is it that, is it easier just to have the paper and then like put it in later, but then realizing that takes person power time and tracking that patient progress? Do we have a place in the electronic health record in which we are tracking specifically their substance use, so that we can know what kinds of care and follow-up to provide, right? And is that clear in the electronic health record? Which seems like pretty straightforward, but I will tell you, as a person who's seen many various kinds of electronic health records, some are like really complicated and convoluted and kind of all, kind of hard to capture, right? So then if you're not able to quickly assess something as a healthcare provider with your limited time, then you may be missing some important things here. So just trying to think about seamless integration. And then community engagement, of course, the importance of I've already established peer navigators, community health workers, thinking about how do we maintain trainings on an ongoing basis. Because to be honest, like most of the time we maybe are focused and attentive to the work that we're doing and using SBIRT, and then like other things call our attention, then we kind of fall off and do something else, and then how do we kind of keep things moving and shaking and relevant, right? And so that often means that we have to provide space for people to have the training, have the time to do that, being able to offer that in our clinics or like in these ways that you are involved in now with like webinars. But all of that is still important that we are able to provide and provision the time for healthcare providers so that they can receive the care that they need and the support they need so that they can use the expert model and really any type of model of care appropriately in a patient setting. And so these are my final thoughts. So final thoughts here is that when we think about HIV and substance use, definitely not an isolated sense of issues, right? Overlapping crises that we're experiencing here that really do, if we want to see some significant shift and change in the way that we provide patient care, I do very strongly believe that it is within the context of integrated and multidisciplinary responses. I don't think that it is up to any one um, person or one healthcare provider entity to be the sole kind of provisioner of this kind of care. And that really it is about that interdisciplinary and multidisciplinary approach. Um, Importantly, if there is kind of pushback that sometimes that as healthcare providers we receive around how public or HIV and substance use are interlinked in the syndemic around that, especially in public health and clinical systems. Being able to say, here are the ways in which we're seeing this show up. Here are the hard numbers that demonstrate that this continues to be an issue, and that we need to be addressing it, right? If the numbers aren't at zero when it comes to new HIV infection rates or substance use overdose, then that means we still have a lot of work ahead. And being able to champion integration. So as you all probably have gathered, I'm like all about the integration, right? So being able to say, how can we integrate a practice in our HIV care already? How do we make that easier for the people? Because surely we don't want things to be harder for healthcare providers, for anybody to be able to provision the care. Because importantly, what we all care about is that we're able to provide really quality care to our patients, and so in doing so means also that we should probably, that's likely that we need to change things up in a clinic setting if and when it's necessary or as we notice the landscape of things changing. So that's important that we're reactive, right? Or ideally preventative, right? In the ways in which we're thinking about provisioning care. And SBIRT, I think, is a really helpful, tangible tool that is most definitely plausible for a lot of settings. And then empower local action. For me, I think it's not enough to just be kind of in the silo of your clinic and just kind of that. There's definitely everyone has different roles, everyone has different kind of bandwidth. And so it's not that any one person has to take it all on, but I think that if you're the person or you want to collaborate with other people around how do we bring in care models, peer education, community-led initiatives that really aim to say like, are we really thinking about our folks who have substance use in these clinic settings, and what more could we be doing, especially if by chance like you are seeing a cut of funds, right? Specifically, we see oftentimes cut of funds across substance use, mental health, and HIV care that anybody who's been in this field has experienced that for quite some time. And so really thinking about how do we engage in local action so that there isn't these gaps in care for our patients so that they can ideally live a healthier life and be in recovery. So that concludes my webinar for today, but I think I